Okay, now let's start with the second section of the cardiovascular system. In this, we'll be starting with chapter 239, which is about the physical examination of the cardiovascular system. इस चैप्टर में हम लोग तीन चीज़ें कवर करेंगे. फर्स्ट विल बी द फिजिकल जनरल फिजिकल एग्जामिनेशन, सेकंड इज द कार्डियोवास्कुलर एग्जामिनेशन एंड थर्ड इज द कार्डियक ऑस्कल्टेशन. The physical examination of the cardiovascular system. A cardiovascular system के assessment में firstly we'll focus on history and physical examination. We'll obtain a clinical context like is it an OPD case or emergency case. This also determines the depth of assessment. A decline in physical exam skills is noted at all levels, and this has contributed to an over reliance on imaging. आजकल लोग डायरेक्टली रेडियो इमेजिंग की तरफ ज़्यादा टेंडेंसी रखते हैं. सो स्टिल फिजिकल एग्जाम रिमेन्स वाइटल इन रिस्क स्ट्रैटिफिकेशन. हम लोग ये बता तो सकें कि कितना रिस्क है, लाइक एक्यूट कोरोनरी सिंड्रोम है, हार्ट फेलियर है, क्या है, अर्ली क्लिनिकल डिसीजन मेकिंग, एंड ऑल्सो इन बिल्डिंग अ पेशेंट डॉक्टर रैपो. लाइक if you diagnose the case efficiently, then you're a good doctor in the eyes of the patients, obviously. Okay, next up is the general physical examination. We assess the general appearance, age, posture, discomfort, dyspnea, and diaphoresis. We obtain information about position preference, like वो बैठा होता है, pericarditis में the patient wants to sit, and this also offers other diagnostic clues. Now we have to look for the signs of chronic illness on syndromic features like Marfan syndrome, Holt or trisomy of 21. We have to rule out that also. Next up, we measure the height, weight, calculate BMI and BSA, body mass index and surface area. We calculate waist circumference and waist hip ratio to predict long-term cardiovascular risk. And we continuously assess mental status, alertness and mood of the patient as well. Now skin examination is also very important here because we see for cyanosis. It can be central due to right to left shunts in the heart or lungs, or it can be peripheral, which is called acrocyanosis. It can be due to poor extremity perfusion from heart failure, shock or vasoconstriction. So like whether it's central or peripheral, हम लोग इसका ये पता कर सकते हैं. Next up, differential cyanosis. Lower is more like cyanosis in lower limbs is more as compared to upper limbs, and patent ductus arteriosus with pulmonary hypertension also presents this. Now they can be telangiectasias, like there are subcutaneous hemorrhages. They can be Osler-Weber-Rendu syndrome, in which lips, tongues and mucosa and pulmonary AVMs, and there is right to left shunt. There can be malar telangiectasia. It is seen in mitral stenosis or scleroderma. Skin discoloration. Bronze skin can indicate hemochromatosis, and jaundice can indicate congestive hepatomegaly in RHF. We have to check for sclera first, and then we go to the skin part. Okay, now there are xanthomas. If the xanthomas are along tendons or extensors, they are called hereditary lipid. They can be due to hereditary lipid disorders. If they are on palmar crease xanthomas, they can be due to type 3 hyperlipoproteinemia. And eruptive xanthomas and lipemia retinalis, they confer to severe hypertriglyceridemia. There can be some other skin findings like pseudoxanthoma elasticum, which presents like cobblestone axilla or neck, and premature atherosclerosis. There can be lentiginosis, example Carney syndrome with HCl myxomas. There can be sarcoidosis, lupus erythema nodosum. We can suspect with cardiomyopathy or arrhythmia. The head and neck examination, poor oral hygiene or dental disease, they can result in potential endocarditis. Syndromic clues can be obtained like if there is high arched palate, it can be Marfan syndrome. If there is bifid uvula, it can be Loeys-Dietz syndrome. If the tonsils are orangish, it can be Tanger's disease. If there is hypertelorism, low set ears, micrognathia, it can be congenital heart disease. In eyes, we can see if there is blue sclerae, it can be due to osteogenesis imperfecta. Arcus senilis, it's non-specific, but of course we can like examine the eyes for the same. Fundus examination में हमें when we have to do fundus examination, when there is a chronic lifestyle disorder like hypertension, diabetes, atherosclerosis, उसमें वैसे भी we do fundus examination. We can look for Hollenhorst plaques, retinal artery occlusion, which can be due to some embolic source. Now, in the nose and ear examination, relapsing polychondritis, which will result in inflamed pinna or saddle nose, or Wegener's granulomatosis, it can result in saddle nose deformity as well. Now, in chest examination, we look for surgical scars if there is any sternotomy like cardiac surgery, thoracotomy, intraclavicular pacemaker or ICD inserted. हम लोग चेक करेंगे फॉर एनी प्रोमिनेंट चेस्ट वॉल वेन्स लाइक इफ देर इज सब सुपीरियर वेना केवा ऑब्स्ट्रक्शन. ओके, वी कैन चेक फॉर चेस्ट डिफॉर्मिटीज, पेक्टस क्रेनिएटम और एक्सकावेटम, CTD like Marfan. Okay, we can check for barrel chest like in COPD with tachypnea. Axillary muscles are used more, so the chest can be barrel like. Kyphosis of ankylosing spondylitis, we can suspect aortic regurgitation. And straight back syndrome, we can suspect associated with mitral valve prolapse. Asymmetric chest is suggestive of congenital cyanotic heart disease, while respiratory findings like wheeze, stridor, adventitious sounds, edema, pneumonia, pleuritis, these also all can be obtained from chest examination. Next up, abdomen. Abdomen mein we will examine displaced cardiac impulse to epigastrium. It can be indicative of obstructive lung disease. Hepatomegaly, congestive hepatomegaly results in chronic RHF, and systolic pulsations are seen in severe tricuspid regurgitation. Splenomegaly can be suggestive of infective endocarditis, like it's a chronic symptom. Ascites है अगर तो advanced right hepatic failure हो सकता है. कंस्ट्रक्टिव पेरिकार्डाइटिस हो सकता है, सिरोसिस, मैलिग्नेंसी. Elevated JVP and ascites do indicate a cardiovascular etiology per se. Now, abdominal aorta, it's palpable in thin patients between epigastrium and umbilicus. Screening ultrasound is more preferred than palpation, of course, for abdominal aorta detection. Okay, arterial brutes suggest high grade atherosclerosis. The location may not be clear, but they do suggest. Okay. Now, in extremities, we assess temperature, color, clubbing, nail findings, digital deformities. Like if there is clubbing, then they can be central, right to left shunt, endocarditis, hypertrophic osteoarthropathy. Like okay, there can be some terms जो आपको अभी समझ में नहीं आए, but as we progress with the chapters, all these terms will be clear. Okay, we are not investing our time right now in understanding the basic word meanings. Okay, we are just covering whatever basic general physical examination can be done in a patient of heart disease. Syndromic findings, if it is Holt-Oram syndrome, the thumb will be fingerized, like thumb will appear like a finger only. In Marfan syndrome, there are arachnodactyly, like their long fingers, positive wrist and thumb signs are there. Some signs of endocarditis, Janvey lesions, non-tender on palms and soles. There are oscillar nodes, tender on fingered and toe pads. We have read this in microbiology also. Okay. Splinter hemorrhages, they are may be seen mid nail bed. There can be linear petechiae in the mid nail bed. Now, very important feature which we can see, which we do see in heart patients is edema. With increased JVP, there is volume overload. They are in CHF or constrictive pericarditis. Without increased JVP, there can be hypoalbuminemia, venous or lymphatic obstruction, venous insufficiency, varicositis, venous ulcers, hemosiderin. All these suggest venous insufficiency. Dihydropyridines, they cause pitting edema, and Homan sign is a poor sensitivity or specificity, but it can be used for deep venous thrombosis. Now, there can be some ischemic signs like if there is muscle atrophy, hair loss, it can be due to arterial insufficiency or neuromuscular diseases. So, the key clinical insights are JVP and S3, third heart sound, are important predictors of heart failure. Okay, increased jugular venous pressure and S3, the third heart sound, which is not physiological. S1 and S2 are physiological, S3 and 4 are pathological. Accurate murmur analysis, if we do, it also gives clue to valvular or congenital heart disease. Bedside exam findings help assess the pretest probability before test. And physical examination, of course, it strengthens the doctor-patient relationship and clinical acumen. Okay, so this completes our general physical examination. Now we come to specific cardiovascular examination. First one being the jugular venous pressure JVP and waveform. So what's the importance of JVP? JVP is the single most important bedside measurement for estimating volume status and right arterial pressure. Like we know कि right atrium से JVP का like we have to, if we have to diagnose what's the pressure inside the right side of the heart, we calculate the jugular venous pressure. The internal jugular vein is preferred over the external jugular vein due to its direct connection with the superior vena cava and the right atrium. Although the external jugular vein is more superficial, it contains valves and is not reliable for waveform analysis. However, it can be used to differentiate high versus low CVP in clinical settings. So mostly we use internal jugular vein. What's the technique for measurement? Traditional measurement involves assessing the vertical height between the top of the jugular pulsation and the angle of Louis, which is the sternal angle. Like we use a scale if you have done this in your physiology practical. A vertical distance of more than 4.5 centimeter at 30-degree elevation is considered abnormal. The actual distance between the mid right atrium and sternal angle varies with body size and angle of examination. This can cause underestimation of CVP also. Alternative reference points, clavicle, venous pulsation above this level in sitting positions are definitely abnormal, of course. Now, how should be patient position? Patient should be placed in semi-sitting or sitting position with legs dangling. हमें patient को लिटाना नहीं है, like it can be like at an obtuse angle, or it can be at a 90-degree sitting angle. This enhances visibility of jugular pulsation, especially in volume overloaded states. Now JVP is measured in centimeter as to, if we have to convert it into millimeter of Hg, we can divide it by 1.36. Now identifying venous pulsations. These can be mistaken for the carotid pulse. Okay, there's also carotid pulse like which we feel in like if the patient is alive or not, and we touch at the angle of sternocleidomastoid to feel the pulsations. It is the carotid pulse. Carotid pulse is palpable, monophasic and not affected by position or respiration. Like a normal arterial pulse hai. While jugular venous pulsation, it's not palpable, it's biphasic and it varies with posture and inspiration. So jugular venous waveform components क्या है? A wave है, it's caused by right atrial contraction just after P wave and before S1. A prominent A wave seen in reduced right ventricular compliance, and canon A wave seen in AV dissociation, example complete heart block or ventricular tachycardia. An absent A wave is seen in atrial fibrillation. Now next comes after A is the X descent, fall in the arterial pressure after A wave due to arterial relaxation. Then comes C wave, the early systolic event due to pulsing of closed tricuspid valve into the right atrium, and then comes the V wave, which reflects atrial filling during ventricular systole. If there are large V waves, they are seen in tricuspid regurgitation. In severe TR, V and C waves may merge. Okay, so they can produce a ventricularized waveform. There is wire descent, drop in the right atrial pressure following tricuspid valve opening. Rapid wire descent is seen in constrictive pericarditis, and blunted or prolonged wire descent is seen in tricuspid stenosis or cardiac tamponade. Now, some dynamic JVP changes. In inspiration, it's normally this causes a fall in JVP by more than equal to 3 millimeters of mercury. Cosmal signs, cosmal breathing, it's a rise or lack of fall in JVP during inspiration. This can result into that. Suggests constrictive pericarditis. Okay, classic constrictive pericarditis is suggested by this. This is also seen in restrictive cardiomyopathy, massive pulmonary embolism, RV infarction, right ventricular infarction, advanced left ventricular failure, and post cardiac surgery. Now, abdominal jugular reflux (AJR). It's used to detect venous hypertension and volume overload. How it's done? Apply firm pressure to the right upper abdomen for more than equal to 15 seconds. A positive test is by sustained rise of more than 3 centimeter in jugular venous pressure. This must be assessed after 10 seconds to avoid respiratory artifacts, and patient must not perform Valsalva or breath holding during this maneuver. AJR is a reliable bedside indicator of elevated right-sided pressure and predicts PCWP more than 15 mmHg in heart failure. Now, what's the clinical significance? It's a surrogate for right atrial pressure, which correlates with pulmonary capillary wedge pressure (PCWP). In advanced heart failure, right atrial pressure is more than 10 mmHg on exam, predicts PCWP more than 22 mmHg with 88% accuracy. इसकी prognostic value ये है कि elevated JVP correlates with increased risk of hospitalization, mortality and worsening heart failure. Of course, it's also predictive in asymptomatic left ventricular dysfunction. So the JVP is essential bedside tool for assessing volume status and right heart function. It's a correct technique and understanding of waveform components are vital for accurate interpretation. Abnormal findings such as Canon A waves, ventricularized V waves, Cosmol sign, and positive AGR also help localize the pathology of the jugular vein. And elevated JVP carries diagnostic and prognostic implications in heart failure and other cardiovascular diseases. Okay, so this was the first clinical tool of cardiovascular examination, which was jugular venous pressure. Next up is blood pressure. Of course, the importance, though usually done by medical assistant, BP measurement should be repeated by the clinician. Accuracy depends on body position, arm size, time and placement, device and cuff size, measurement technique, and examiner's proficiency. All these factors are contributory to how specific and how correctly the blood pressure of the patient will be done. Okay, now optimal technique for BP measurement: position seated, arm at heart level, feet on the floor, and back should be supported. Relaxation: the patient should be allowed to rest for 5-10 minutes before measurement. In supine position, the arm should be raised to mid right atrium level. The cuff dimension: length is 80% of the arm circumference, width should be 40% of the arm circumference. What are the common errors? If there is small cuff, it results in overestimation of blood pressure. If there is large cuff, it results in underestimation of the blood pressure. What's the procedure? Inflate 30 mm of mercury above expected systolic level. Deflate at 2 to 3 mm of mercury per second. First Korotkov sound heard when the sound starts, it's the systolic blood pressure, and when the sound ends, like which is the fifth Korotkov sound, that marks the diastolic blood pressure. You have to record phase 4 and 5 if diastolic is very low, like in chronic AR. PP measurement sites and variability, best it's done at brachial artery. Alternative sites are radial, popliteal, and pedal pulses. What are the trends? Systolic and diastolic. Systolic increase and diastolic decrease in more distal arteries. Measured in both arms, a difference of more than 10 mmHg is abnormal. It suggests some vascular pathology. Like right and left arm, अगर इनमें difference 10 mm of mercury से ज़्यादा है, then of course it suggests something is wrong with the blood vessels. Like systolic pressure usually 20 mmHg higher than the arm, of course due to gravity. Greater leg arm difference seen in chronic AR or calcified peripheral artery disease. Okay. Now ankle brachial index ABI calculated as ankle systolic pressure upon high brachial systolic pressure. It's a strong predictor of long-term cardiovascular mortality. Now blood pressure variants: white coat hypertension. Of course, like if the patient is in front of the doctor, the clinic BP is almost mostly more than equal to 130 by 80 mmHg, 3 readings, and out of clinic less than 130 upon 80 millimeter of Hg, 2 readings. No target organ damage, may not need drugs, but at risk for future hypertension maybe. There can be masked hypertension, normal clinical BP, but elevated out of the clinic BP, suspected with atherosclerosis and target organ damage. 24-hour ABPM, higher predictive value for CV outcomes than clinic BP. Now there is some orthostatic hypotension. It's defined as reduced systolic more than 20 millimeters of mercury or reduced diastolic more than 10 millimeters of mercury within 3 minutes of standing. Okay. There is absent compensatory tachycardia. It suggests autonomic dysfunction like diabetes or Parkinson disease. And exacerbating factors are like age, dehydration, drugs, meals, deconditioning, temperature, humidity, etc. Okay, so this was about the blood pressure, which was the second clinical aid. Third up is the arterial pulse. Sites of pulse palpation: carotid pulse just after ascending carotid pulse, aortic epigastrium above umbilicus. Peripheral pulses like subclavian, brachial, radial, ulnar, femoral, popliteal, dorsalis, pedis, posterior tibial, temporal arteries in suspected temporal arteries on PMR. Of course, mostly we commonly palpate the radial artery. There's Allen's test, it's Palmar artery supply before radial artery instrumentation. Okay. Next up, examination parameters. There should be symmetry. We have to comment on volume, timing, contour, amplitude, and duration. Auscultation can help detect the pulse delay. Carotid upstroke must be auscultated before palpation. And we should avoid excessive carotid pressure because there can be a risk of carotid hypersensitivity or syncope. Okay. Now, the pulse character and contour. It becomes more rapid and spiking distally due to wave reflection. The determinants are stroke volume, ejection velocity, vascular compliance, systemic resistance, caution and stiff arteries. We have to take caution and stiff arteries like old age, hypertension, PAD. What are the abnormal pulse patterns? Pulsus parvus et tardus, like weak and delayed pulse, severe AS. Anarchotic pulse, naused or slow upstroke, there can be S. Cor- Corrigan's pulse, sharp rise and fall, there can be AR. Bispherin's pulse, two systolic peaks can be an AR or HOCM. And dicrotic pulse, one systolic and one diastolic peak, it can be seen in sepsis or IABP. Now the special pulse findings, pulsus paradoxus, 10 millimeter mercury fall in systolic BP during inspiration. It's called pulsus paradoxus. It's seen in tamponade, PE, hemorrhagic shock, asthma, COPD, tension pneumothorax. The measure using it's measured using slow deflation and noting inspiratory expiratory differences in Korotkov sounds. Pulsus alterans, it's beat to beat variation in pulse amplitude. It's seen in left ventricular dysfunction associated with T wave alterans, more risk of arrhythmias. Okay, now pulse and aneurysm recognition. Like if there is ascending aortic aneurysm, it may cause right parasternal pulsation. If there is abdominal aortic aneurysm, it can result in visible or palpable. It can be visible or palpable in thin patients. It requires imaging. And if there is femoral popliteal aneurysm, then also we have to evaluate this abdominal aortic aneurysm in these patients also. Okay, now the localization of peripheral artery obstruction. Pulse difference between common femoral and popliteal arteries suggests like there is some superficial femoral artery disease. Now, inflow disease may coexist. Routine auscultation of carotid, subclavian, abdominal, aorta, and femoral arteries. Like that's the best we can do. Presence of a brood does not correspond to degree of stenosis. And there's nothing like if the absence of brood and there's no stenosis. Okay. Diastolic brood or thrill, it can be there in severe obstruction or AV fistula. There is something called pulse oximetry, finger toe saturation difference. If this is more than 2%, it can be a suggestive of PAD, and similar accuracy to ABI is there. Okay, so now I think we come to the last part, which is the heart cardiac auscultation. Firstly, we inspect and then palpate. So first is inspection. LV apex beat visible at fifth intercostal space, mid clavicular line, especially in thin individuals. Visible pulsations, if there are some elsewhere, they are abnormal. In right parasternal pulsation, ascending aortic aneurysm, epigastric impulse in thin or tall COPD patients may be there. It may resemble a pulsatile liver. Upon palpation, the palpation is done in supine 30-degree or left lateral decubitus position. Left ventricular impulse less than 2 cm, brisk and best felt at end expiration. What are the abnormal findings? अगर pulse displaced and enlarged apex है, then there can be left ventricular dilatation. If there is sustained impulse, it can be a result of pressure overload. Okay, it can be AS or hypertension. Presystolic impulse S4, it can be due to reduced left ventricular compliance. Palpable S3 can be due to early rapid filling seen in heart failure. Left ventricular aneurysm can result in ectopic impulse. HOCM can result in triple impulse like palpable S4, and after that even comes a bisphenol systolic pulse. Now, the right ventricular abnormalities, if there is right ventricular overload, we can see sternal lift. Confirmatory signs are TR, like CV waves in jugular venous pressure, and PH or loud or palpable P2. Next up, severe right ventricular enlargement may mask left sided signs. Zone of retraction between right ventricle and left ventricle impulse in overload, and they can be thrills, systolic or diastolic thrills, which can localize murmurs due to high velocity turbulent flow. Now coming on to the auscultation part, heart sound and the clinical significance. Ventricular systole and heart sounds. Ventricular systole is the interval between the first heart sound and the second heart sound. First heart sound S1, it's the closure of mitral and tricuspid valves. Normal splitting sometimes heard in young patients or those with right bundle branch block due to delayed tricuspid valve closure. Determinants of S1 intensity क्या है? First, distance anterior mitral leaflet travels to annular plane. Valve leaflet mobility, left ventricular contractility, and PR interval duration. What are the clinical notes that we can take from S1? If there is a loud S1, it can be suggestive of early rheumatic mitral stenosis, hyperkinetic circulatory states, short PR interval. If we hear short S1, it can be due to late MS mitral stenosis, which can be of rigid or calcified leaflets. It can be due to use of beta blockers, and long PR interval can be there. Left ventricular contractile dysfunction can also be there. Next are factors inducing reducing the heart sound intensity. Increased distance from stethoscope to heart sounds can reduce these intensity. Okay, like mechanical ventilation, obesity, obstructive lung disease, pneumothorax, and pericardial effusion. All these can contribute to the same. Next up, the second heart sound S2 components. It's the closure of aortic A2 and pulmonary P2 valves. Normal physiologic splitting A2 P2 interval widens during inspiration due to delayed pulmonic valve closure, pulmonary valve closure. This narrows during expiration. That's normal. The variation seen, wide splitting seen with RBB, delayed P2, severe mitral regurgitation MR, causing premature aortic valve closure. Fixed splitting, wide A2P2 interval that doesn't vary with respiration, characteristic of atrial septal defect. Okay, so all this knowledge we can use clinically. Like if there is no variation or fixed variation that doesn't vary with respiration, that can be due to atrial septal defect. Now, narrow or absent splitting, single S2 seen in pulmonary arterial hypertension, and reversed or paradoxical splitting. It's pathologic delay in aortic valve closure, like left bundle branch block (LBB), right ventricular pacing, severe aortic stenosis, hypertrophic obstructive cardiomyopathy (HOCM), and acute myocardial ischemia. Splitting narrows during inspiration, which is opposite to normal physiology. Okay, so that's paradoxical splitting. Now, loudness. Louder P2, intensity greater than A2 at the base, palpable over main pulmonary artery or lower left sternal border. It suggests pulmonary hypertension. Diminished A2 or P2 in AS or pulmonary stenosis, aortic stenosis or pulmonary stenosis, respectively, may cause single S2. Okay, now the systolic sounds. Ejection sound, high pitched early systolic sound coinciding with carotid pulse upstroke, commonly associated with congenital bicuspid aortic or pulmonic valve disease. Also heard in isolated aortic or pulmonary root dilatation with normal valves. And this softens or disappears as valve calcifies in bicuspid aortic valve diseases. Pulmonic ejection sound moves closer to S1 as PS severity increases. And pulmonic ejection sound decreases with inspiration, best heard at the lower left sternal border. This was ejection sound. Now some there are non-ejection sounds or clicks. These occur after carotid upstroke. These are associated with mitral valve prolapse (MVP). They may be single or multiple. The click murmur complex moves away from S1 with increased preload. Example, squatting. And this moves closer to S1 on standing. So these were the ejection and non-ejection sounds. Now there are some diastolic sounds. Opening snap OS of mitral stenosis, high pitched sound shortly after S2. The interval between A2 and OS inversely related to left atrial to left ventricular diastolic pressure gradient. OS and S1 intensity decrease as mitral leaflets calcify and stiffen. Pericardial knock PK, high pitched sound slightly after OS. Okay. Corresponds to abrupt stop in ventricular expansion after tricuspid valve opens. And this is seen in constructive pericarditis. This is related to exaggerated wide descent in jugular venous waveform. There is something called as tumor plop, low pitched sound heard at some arterial atrial myxomas. It occurs due to tumor prolapsing into mitral valve during diastole. This is position dependent. So these were S1, S2 ejection sounds and diastolic sounds. These are normal physiologic sounds. Now comes third heart sound, the S3. This occurs due to rapid ventricular filling in early diastole. It's normal in children, adults and young adults, but in older adults it indicates heart failure. Left-sided S3 lower pitched and best at left ventricular apex. Right-sided S3 best heard at lower left sternal border, and this is louder with inspiration. Presence of S3 in heart failure predicts morbidity and mortality. Equally prevalent in heart failure with preserved or reduced left ventricular ejection fraction. Now there is fourth heart sound. This occurs during atrial contraction in late diastole or pre-systolic phase. This indicates stiff or hypertrophic left ventricle requiring atrial contraction for ventricular filling. This is seen in chronic left ventricular hypertrophy and myocardial ischemia, and this is absent in atrial fibrillation due to lack of organized atrial contraction. So normally the normal splitting can be widened on inspiration A2 then P2. Wide splitting seen in right bundle branch block and severe MR. Fixed splitting seen in septal defects, okay, atrial septal defects. Narrow or single S2 seen in pulmonary hypertension. A paradoxical reverse splitting seen in left bundle branch block, severe AS, HOCM, etc. Lastly, the cardiac murmurs. What are murmurs? We have discussed them slightly before also, but let's discuss them in detail. These are audible vibrations caused by turbulent blood flow. These are classified by cardiac cycle phases like systolic murmurs, diastolic murmurs, continuous murmurs. They may be innocent, like they may not indicate any disease, or they may be pathologic. They not all indicate structural disease. What are the key acoustic features? Timing, duration, frequency, intensity, and configuration. Location, radiation, whenever response can also be indicative. So there are grade 1 to 6 intensity scales, and thrill appears at grade more than equal to 4. Systolic murmurs. Early systolic murmurs seen in acute severe MR. Uh, there can be decrescendo murmur due to rapid rise in left atrial pressure. In acute TR, they can be left lower sternal border. This increases with inspiration and is associated with regurgitant CV waves. There can be mid systolic or ejection murmur. It begins after S1, ends before F2, crescendo, decrescendo. And in aortic stenosis, like it can be seen in its most common adults, findings suggest severe aortic stenosis. Parvus et tardus carotid pulse can be seen. Late peaking murmur, grade more than equal to 3 can be seen. Soft A2 and S4 sustained apical impulses can be seen, and this also radiates to carotids. So what's the differentiation? Like from aortic sclerosis, in aortic sclerosis there is no obstruction and Doppler velocities less than 2.5 meter per second. What can be the other causes of such murmurs? Pulmonic stenosis, second LICS, HOCM, low LSB or apex, and it's maneuver sensitive. ASD, increased pulmonary flow, mid LSB, and functional murmurs like fever, anemia, thyrotoxicosis, pregnancy. Now there can be late systolic murmurs. In mitral valve prolapse, they can be heard at apex, often preceded by non-ejection click. What maneuvers can be performed? Louder with standing or Valsalva maneuvers, and softer with squatting. There can be something called as holosystolic murmurs. These are constant intensity murmurs. They span entire systole from S1 to S2. They can be mitral regurgitation in apex, which radiates to axilla, increases with hand grip. They can be tricuspid regurgitation, lower LSB, increases with inspiration, Carvalho's sign, CV waves in JVB, and pulsatile liver can be there. In ventricular septal defect, they can be mild LSB, often with thrill. Okay, so please don't get afraid. डरना नहीं है हमें कि इतना सारा डेटा है. It's like more or less like a summary of whatever we are going to study after this chapter. Okay, so just hear the terms, make yourself familiarized to them. जब ये आगे वापस आएंगे, then of course you'll be able to relate and learn. Lastly, the diastolic murmurs. These always indicate structural heart disease. Diastolic murmurs are non-physiological. Aortic regurgitation or acute aortic regurgitation, they can be soft, short diastolic murmur. In chronic, they can be decrescendo blowing murmur along the LSB or RSB, left sternal border, right sternal border. They can indicate some aortic root disease. They can be bounding pulses, wide pulse pressures. They can be Austin Flint murmur, like mid-late diastolic rumble at apex due to left ventricular inflow obstruction, and this decreases with vasodilators. There can be pulmonic regurgitation, LSB, often due to pulmonary hypertension, loud S2, parasternal heave, soft lower pitched after repair of TOF. Mitral stenosis, low pitched rumble at apex in left lateral decubitus, opening snap OS present in early disease, and pre-systolic accentuation present only in sinus rhythm. There can be some mimickers like functional MS, example in severe MR or TR or large ASD. The in Austin Flint murmurs and atrial myxoma, complete heart block, and acute rheumatic valvulitis. Now, there can be tricuspid stenosis. It's rare but often masked by left-sided sounds. It's similar to mitral stenosis. There can be something called as continuous murmurs. Third type of murmurs: systolic, diastolic, and continuous. These occur throughout systole and diastole due to continuous pressure gradient. They can be seen in patent ductus arteriosus PDA, best heard between second and third intercostal space, the best example. And other causes can be ruptured sinus of valsalva aneurysm and AV fistulas, example dialysis axis. Okay. Now some benign types, they can be cervical venous hum in children, supraclavicular obliterated by pressure, and mammary souffle in pregnancy. This disappears with pressure. Okay, so in dynamic auscultations, what can be the maneuvers done? In inspiration increases right-sided murmurs, expiration increases left-sided murmurs, hand grip increases sounds in MR, VSD, AR, and decrease in AS, HOCM. Okay, vasodilators, they reduce the sounds in MR, VSD, AR, and increase in MS due to increased cardiac output. Squatting increase in preload and afterload. It results in increased sounds and results in decreased sound in MVP, HOCM, and also increase in MR. Standing position decreases the sounds in preload, increases them in MVP, HOCM, and decreases them in MR. Now, Valsalva strain phase, most murmur sound decrease, but the sounds increase in MVP and HOCM. And post PVC peat, sound increase in aortic stenosis, in HOCM, and no changes in MR, mitral regurgitation. Now, prosthetic valve murmurs. Like sometimes in like rheumatic heart disease, there are prosthetic valves fitted to the heart. So the bioprosthetic valves can result in some kind of murmurs. They can be mitral bioprosthetic valve. The result in grade 1 to 2 mid systolic murmur at left sternal border, and low and soft mid diastolic murmur only in LLDP or post exercise. Aortic murmurs always has mid-diastolic murmur grade 1 to 3. High-pitched or holosystolic apical murmur. This suspects some paravalvular environmental reagitation or degeneration. There can be some mechanical valves, the dysfunction suspected with loss or change in opening or closing clicks. High pitched systolic mitral or diastolic decrescendo aortic. Both these indicate paravalvular regurgitation. And valve thrombosis can result in shock, muffled sound, soft murmurs. There can be something called as pericardial diseases like the infection of the pericardial layer. There can be pericardial friction rub and pericardial fluid, highly specific for acute pericarditis. Leathery or scratchy, this can be, it may be due to three component systole, early diastole, and pre-systole. And this also can be a two component or monophasic murmur. We have to listen to this in multiple positions, and this disappears with increasing infusion volume. What's pericardial tamponade? In that also, like if the pericardial layer is about to or breaks, this is diagnosed by pulsus paradoxus more than 12 Hg. Sensitivity is 98% and specificity is 83%. Okay, so this completes our chapter 239. Basically, it's more kind of an introductory chapter. You can go through the video multiple times so as to make yourself familiar with the all the diagnostic modalities that we have. And please don't get afraid with all these terms as we start with the next chapter, which is about echocardiography, electrocardiography. We'll just keep on using all these terms again and again. And so when this unit uh, when this unit will be almost at the level of completion, आप लोग अच्छे से हर चीज़ को comprehend कर पाएंगे. Okay, so don't get afraid. Try to learn and memorize some techniques, some terms from this lecture as well. And make sure you study long well. Okay. So like, share, subscribe. Thanks for watching.